Okay, so the croup syndromes are things that affect the larynx, trachea, move down into the bronchi. So first, we're going to start with acute epiglottitis. This is a really scary one. We don't see as much of it anymore because of the Hib vaccine. So what happens is the epiglottis becomes inflamed. It is bacterial. It is usually H. flu, Haemophilus influenza. This begins with abrupt onset. It progresses rapidly. They complain of a sore throat and pain on swallowing. This kid looks very sick. They're running fever. Now, what's happening, remember the epiglottis is the little flap that protects your airway when you swallow. So imagine if that flap is now swollen to the size of a cherry. It actually looks like a cherry. It's round and swollen and red. So it's threatening to obstruct their airway. So the child is going to insist on sitting upright, usually in a tripod position with their jaw kind of jutting out, and their tongue out, and they're drooling. They're not swallowing. They're irritable, restless. They appear to be scared because they are scared because they can't breathe. If a child has symptoms of epiglottitis, we never, ever, 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 ever examine it. Do not allow anyone to examine it. If a resident comes around and wants to see it, oh, that's cool. No, not going to look at it. If a nursing student wants to look at it, not going to look at it. If you do look at it, the epiglottis looks like a cherry. Okay, it's round and red. But what happens is when you try to visualize it, you can cause it to suddenly swell more and completely obstruct the airway. So a child comes in with those symptoms. They're sitting up, sticking their jaw out, drooling, being very still, and they look scared, maybe fussy. You don't move them. You keep them in the parent's lap, and you get whoever is the absolute best at intubating kids in the facility. You get them their stat. You get an intubation tray and a tracheostomy tray. Okay. So intubation is done if possible. If not, they have they do a tracheostomy. You secure the child's airway before you attempt any other care. So we're not going to hold this kid down and start an IV because we're going to obstruct their airway. They're going to scream and cry and fight and obstruct their airway. So we secure the airway before we attempt any other kind of care. Until intubation, if they will tolerate having humidified O2 aimed at their face, we do that. If it makes them cry or fight, we do not. We want this kid sitting in their parents' lap or their caregiver's lap, allowed to sit however they're comfortable, and do not upset them until they're intubated. Okay. Once they're intubated, we have an airway, then antibiotics are given. Cephalosporins are the first choice. Steroids also are given to get that swelling down. When the epiglottis returns to normal size, which is usually about 3 days of antibiotics, then they get extubated. At that point, as long as they're stable, they may be discharged to complete their antibiotics with a 7 to 10 day oral antibiotic course. Anybody else any other children who's in close contact with that child and they're under 4 years old needs prophylactic treatment. Nursing care, their droplet precautions. Again, until their airway secured, you don't upset them. You don't let anybody look at their throat. You leave them alone until whoever is the best at intubating gets there and gets it done. And then you monitor their respiratory status very closely. Cool mist or humidified O2 provide comfort and reassurance. We see a lot less of this now because we have a vaccine against Haemophilus influenza. This is the Hib vaccine. Okay, the next croup we're going to talk about is acute laryngotracheal bronchitis, LTB. This is usually viral, and it usually is a descending infection from an upper respiratory infection. So they start with a cold, and this moves down. It's when the mucus membrane of the larynx and the trachea become inflamed, and that narrows the airway. They get swollen, make more mucus. So what does this look like? They gradually have a low grade fever kind of gradually begins. It's not a sudden thing. They may go to bed and wake up with a barking cough. Stridor, when they're breathing in, you hear that really loud. I can't ever do that without coughing, but it's that really tight stridor. They may have substernal retractions. They look like they're in respiratory distress. They may be hypoxic. Now, parents, kid wakes up, they're coughing, they're can't breathe, they have a stridor, they stick them in the car, or call an ambulance, head to the hospital. Their symptoms may get better going into the cool night air. Okay. Medical management, this is self-limited, but their airway is at real risk. And so they may need to be admitted to make sure they maintain an airway. They often will give racemic epinephrine to open the airway, corticosteroids. In severe cases, they give Heliox. It's a mixture of helium and oxygen, and it opens the airway, decreases swelling. Occasionally, they need to be intubated and put on a ventilator. So this is supportive care until it goes away on its own. Remember, self-limited means if the host survives, it'll go away on its own. Nursing, we need to be really, really observing their respiratory status. Cool mist helps. They may be in a mist tent. At home, they might have a humidifier. And then we might be giving those meds. This child may be discharged from the ER if they stabilize, or they may be admitted if they don't stabilize pretty quickly, or if they're worried about their airway ongoing. So we need to be monitoring them, but we also teach the patients the signs of respiratory distress. We teach them get a cool mist humidifier, and we teach about hydration. Okay, next one is acute spasmodic laryngitis, and this one actually can look like LTB, but it's not. They don't know what causes this. It may be associated with allergies. Some kids may have recurrent episodes, so they may do this over and over. What happens, a child wakes up in the night with a barking cough and inspiratory stridor, just like LTB, but there's little to no inflammation. If they go back to sleep, they wake up in the morning and they feel fine. They don't feel sick. Respiratory distress is usually less severe with LTB. Medical management and nursing care are similar. So they're less likely to get in real trouble, but they can. And usually they go to sleep and wake up in the morning and they feel fine. Bacterial tracheitis can be a complication of LTB. And it's when the trachea becomes inflamed and it causes thick, purulent secretions. Those secretions can be thick enough and there can be enough of them to impede the airway. So we might see this in a kid who's recently had an upper respiratory infection. They can develop a croupy cough. Stridor that doesn't get better when they're sitting up. That stridor is there all the time. They probably don't have drooling or difficulty swallowing. They may have a high fever. They may have thick, purulent secretions, and they may be in respiratory distress because of those secretions. This is managed medically with antibiotics, antipyretics, managed fever, oxygen. Sometimes they require intubation and ventilation, nursing care, close observation, teaching. Okay, same things. We're just observing them to make sure that they recover from it with those antibiotics. Okay, in the next section, we're going to start talking about lower respiratory disorders.